Hello, folks. What's up? Today it's Wednesday. It's the 30th of October, 30th of October, I guess, 2024. We are live. It's Wednesday morning. I was just out doing stuff out of home, out of my home office. That's why I'm in this fancy clothes. So I thought, why not just live stream? We're going to get a few CT scans and MRI scans from the queue. It's mostly in ER and some outpatient exams, so we can report. It seems the queue is full already. It's 12 past 9 in the morning and it's already chaos. So let's try to put some order in this chaotic setting. I have already downloaded the first exam. It's a couple of exams as I recall. If you guys are new here, my name is Galvani. I'm a diagnostic radiologist from Brazil. And this is what I do. I do this every single day. I read and report CT scans and MRI scans from the queue, from the emergency, from an outpatient setting, and I stream it for about 1 hour, 1 hour and a half. And you guys can see all that I can see because I share my screen, the screen of the workstation, and we try to figure out stuff together as we go. Stay put, hit that like button, subscribe to the channel, and I'm trying to stream about 3 times a week. This is my first stream this week because Monday and Tuesday was hell and I didn't have energy to do streaming. Streaming takes a lot of energy and effort because, as you guys have noticed, I'm not a native English speaker, so it's a effort to work, to stream, and to speak proper English as much as I can. So I'm trying to keep this as a routine to stream at least 1 hour 3 times a week, but it's hard, so I can't really predict when I'm going to be online again. I'm aiming at Mondays, Wednesdays, and Fridays in the morning here in Brazil. So, if you guys subscribe and activate that notification bell, you will receive a notification as soon as I post a new video or I schedule a live stream as this one today. Also, on the description below there is a link to my Discord server. It's still quite small, but I'm around there every day, so if you guys want to chat, that's a great place to chat. And we can video chat, audio chat, and chat text. And also I send notifications of new videos and live streams there as well. So I'm just stalling you guys because it's 9:15 now, 9:16. Let's start the stream and see. This is a male patient. He is 76 years old and it says he has some kind of pneumonia, and we gotta find out if it is true and how bad it is. So this is a very old patient, so we are supposed to find all kinds of funky stuff in his chest. Excuse me, coffee is trying to get out, but I just swallowed it back in. So this is soft tissue window and this is lung soft lung window and recon, so we can properly diagnose anything related to the parenchyma. So you guys are new here, so I'm going to hit an MPR so we can look for bone lesions, fractures, degenerative disease and whatnot. So you guys say the proper chat interface on YouTube Studio today is broken. It just says something went wrong and there is a cute monkey on the screen. So I'm looking at the chat in my cell phone so I can readily respond to any questions you guys make in the chat. And of course, if you are watching this video after it has been recorded and live streamed, feel free to leave comments, questions, anything, suggestions, really anything you want in the comments section below. I highly appreciate it. So I'm just scanning and rolling bone here on the sagittal view. There is ossification of the anterior longitudinal ligament. There is, of course, spondyloarthrosis, arthrosis of facet and costal vertebral joints. As always, this is, even in this age, it's really not that much. This is as expected for this patient's age group. So no fractures, ribcage seems fine, as much as we can properly tell, because this isn't a trauma patient. This is a patient to look for infectious disease or something else. So we can tell we have micronodules right there, micronodules. They are right there and there. They are mostly centrolobular in distribution. Most of them are cortical. So they are located in the cortical region of the lungs, especially on the upper lobes, less than 0.4 millimeters. No calcification. Yep, no calcification, just soft tissue attenuation. And we also have ground glass opacities scattered all over the parenchyma. Nothing much, just your day-to-day ground glass opacities. This is interstitial disease of some sort. This is what precedes a consolidation, or it's a edema or a infiltration of some kind of the interstitial spaces of the alveoli, the lobes, the segments, and whatnot. So this we also have on the middle lobe and on the lingula, as very commonly, also on the uppermost part of the apex of the lungs, some bands which are fibrosis, and maybe some traction bronchiectasis, which also are quite common. This patient is over 70 years of age, so it's expected. Nothing much. This is acute disease, and it has also some traces of chronic disease. Right here, just notice there is a lipoma on the subscapularis, right subscapularis muscle. I'm not going to report that because it's of non-importance in this case, but it has drawn my attention, so I'm just going to tell you guys this is a lipoma. Nothing much. Little cyst right there. The heart is clearly enlarged, especially the posterior chambers, the left ventricle, which is also quite common in this age group. Is this a enlarged lymph node? Let's measure. Short axis 1.1. Technically, it is enlarged. Could I ignore it? Yes, I could. It's not really anything much. It's probably just a reactive lymph node. There is some subcarinal lymph node right there. I guess it's going to be 1.3, maybe 1.2. Oh, this is wrong. What just happened? I didn't get. What? Ah, right there. So 1.4 centimeters. So it's a proper enlarged subcarinal lymph node. It's worth mentioning. So let's hit D. What? Yeah. Let's see the aorta. The aorta is mildly enlarged also on the ascending segment. And of course, the root of the aorta is 4.4. It's elongated, it's tortuous, and it has also calcifications, just as we could expect. And there is also calcium plaques on the coronary arteries. So we have also to check for the adrenal glands. Adrenal glands are fine. There is some portion of the superior abdomen that has been imaged, so just going to check it out to see if there isn't much of a major disease here. So no major disease. Thyroid seems fine. So we don't have much here, but we can already report this exam. It isn't going much further than this. Just going to, I have already copy and pasted my template. I have a template for people, for old age patients, chest CT scans. So just going to report the bends and the bronchiectasis. I can't really show you the report, both because it's a private information from the patient, so it's illegal to share this, and also it's all in Portuguese. Writing in Portuguese and translating it on the fly to English and the way around, so it wouldn't really matter much, but I have already reported it, the exam verbally to you guys, so let's just give me a couple of minutes for me to send this reported so we can go to the next one. So bronchiectasis and bends. The micronodules. Uncalcified, cortical, centrilobular, less than 0.4 centimeters, and predominantly located on the upper lobe. Yeah. Also, we have ground glass opacities, bilateral, and of not much importance. They are quite common, quite frequent here on the left upper lobe, not much on the lower lobes, but they could be a cause of acute symptoms, so let's report them. And this is it. Let's just report the aorta. It's also enlarged. There are a bunch of calcium plaques. And also the heart is enlarged. There is atherosclerosis of the coronary arteries. And I didn't mention the esophagus because I already analyzed it, and there is no signs of a mass, a tumor, dilatation, anything on the esophagus right there. So it's always important to check for anything on the esophagus of such patients, since it's quite common for these patients to suffer from some kind of terrible disease in this particular anatomical site. So always look for esophageal diseases. There are none in this case, at least that I can tell. Just the lymph node enlargements. I'm just going to summarize this report so it could be readily read by the referring physician in a very fast and objective manner. Just quickie. Nothing much. Just an old age patient that is feverish. So the same patient has also a CT scan of the head, and it says, let's see what it says. Yep, it is right there. It says he has epilepsy. Oh, if that makes any sense to you guys. Epilepsy on a 76-year-old patient. So he must have had a recent seizure, and they are looking for a cause for such terrible event. There is a minor calcification right there. Fine, minor calcification. This isn't a very good looking brain, even though he is 76. This isn't normal aging. This looks like chronic microvascular white matter disease. There is a clear reduction in size of the brain parenchyma, nothing nothing that is extraordinary, but indeed it is. There is calcification of the carotid arteries and carotid arteries and a few of their branches. There is a moderate dilatation of the ventricular system, which is hydrocephalus. There is this tiny calcification on the right parietal segment, lobe. I'd say it's a 0.3 calcification. It is 0.3 centimeters. This is residual, some scar tissue that has calcified, and there is at least mild hypoattenuating ill-defined areas of microvascular white matter disease, especially on deep and periventricular regions. So, are there any justifications? Are there any probable causes for a seizure? In this case, I can't really tell. It seems this patient has no acute disease, just chronic brain disease related to old age, diabetes, and high blood pressure, chronic high blood pressure, as most of the times it is what it is. Fourth ventricle, cerebellum, brainstem is fine. These black stuff right there, it's fat, usually just fat around the cella. Yep, not much here. Let's just report it very quickly so we can move on to the next one. I have a template that is quite like this. I just have to make minor change to it and send this over to the referring physician. Just adding a line about that tiny calcification. Just that. Now I'm going to summarize it. And we are done here. Just a tiny sip from my cold coffee so we can move on to the next one. Next challenge is, let's see what we have here. And here we have, let's see, another CT scan from the emergency of the head. This is a 11-year-old male patient. It says here he is throwing up, and he has some kind of unknown disease. So let's just open this up. We are here. Right there. That is sinusitis. Moderate and diffuse sinusitis, which could be a motive for the headaches. There is a slight dilatation of the temporal horns of the lateral ventricles. This could be just constitutional or due to dehydration. Acute dehydration could be because there is somewhat enhancement, not enhancement, but there is a enlargement of the sulci, the brain sulci. This is in children. This is usually related to dehydration. This patient, it says, is throwing up and has a very severe headache, migraine of some sort. So they are probably looking for any signs of a brain tumor or some kind of bizarre presentation of any childhood intracranial disease. There is no trauma, but there is indeed some sinusitis. So I'm going to report the brain as normal, and I'm going to put a footnote pointing towards the possibility of a sinusitis-related migraine crisis, migraine event. So nothing much here, just grab a normal template for a brain scan, paste it, and set it up. Brain is normal, just footnote. So let's grab another exam. Maybe we could grab a MRI. Are there any MRIs here? So we can, let's see, just CT scans, no MRIs, just let's see here. We have a left knee MRI. I'm downloading it. It says this patient has gone through surgery for some patellar disease. He also has arthrosis and has been complaining of pain, edema, and limitation to walk and to move the knee. So yep, this isn't good. This looks like not as bad as it was described, but it's really not normal. We have a high riding patella right there. We have it's a type 2 Wiberg classification. We have superficial chondral erosions right there and deep erosions right there on the trochlear region of the femur. Also, the trochlear sulcus is flat, the patella is high riding, and there is bone edema, subchondral bone edema right there and right there. So there is mild arthrosis. In these settings, tiny osteophytes. There is also a small joint effusion. We have a thickened and heterogeneous patellar tendon right there. Let's see, the lateral meniscus looks fine. Also the medial meniscus looks fine. Anterior and posterior cruciates are all right. My cell phone just fell down. Just going to put it up again. Yep. And collateral ligaments look okay. And I guess there is also, oh, I'm sorry. There is also some signs of a surgical procedure right there on the medial patellar retinaculum. These ligaments hold the patella in place. So this patient clearly had a event of a lateral dislocation of the patella, and it was put back in place and surgically corrected sometime in the past. And we also have some edema on the soft tissues anterior to the patellar tendon, which could be related to a mild pre-patellar bursitis. So I guess we have all that we need, and we also only looked at 2 sequences of this knee. Let's grab a T1. Yep, it's there. It's really arthrosis, mild arthrosis, patellofemoral arthrosis, and indeed there is a diffuse and advanced tendinosis of the patellar tendon. There is even a small fragment of bone right at the distal portion of such tendon. So this isn't a good sign. There is fibrosis right there, fibrosis on and diffuse signs of a post-operative setting, a operative procedure, a surgical procedure, and there is clear signs of fibrosis on the infrapatellar fat pad, which is quite common whenever the patient goes through surgery like that. This isn't much. This is what it is. So lateral meniscus seem fine. Medial meniscus also just a mild heterogeneity, mild heterogeneous signal in its substance, particularly on the posterior horn, nothing much. The chondral surfaces are fine, collateral ligaments also, and we have indeed a post-surgical setting of a surgically corrected lateral dislocation of a patella, which in itself is high riding, and also the femoral trochlea is flat, is shallow, which are signs of a instability, a patellofemoral instability complex. So I have a normal template for this because this isn't quite common. So I'll grab a normal template and I'll just describe finding after finding in a orderly manner so it makes sense to whoever is going to read this. So most bone and cartilaginous structures are fine. Just describing the arthrosis of the patellofemoral compartment. Yep, this is it right there. And I'm going to describe the instability, the patellofemoral instability. It's a type 2 Wiberg. High riding. Clearly high riding. And we also have a flattened, a shallow trochlear sulcus. And we have a fibrosis right there. Medial patellar retinaculum. It's surgically corrected. Also, we have mild joint effusion. And we have a thickening and diffuse signal heterogeneity of the patellar tendon. No signs of tear, acute tears, just and we also have that soft tissue, superficial soft tissue edema right there. So we have patellofemoral instability, just summarizing it. fibrosis, edema, all that good stuff. Mild osteoarthrosis of the patellofemoral compartment. Some mild effusion. We also have severe chronic tendinosis of the patellar tendon. And a mild edema of the prepatellar soft tissue, especially located on the site of the prepatellar bursa. Which could be the case. So just going to read what I just typed to make sure I didn't type anything just wrong and mistyped anything, just to be sure. No, it's fine. It seems fine. Should be fine. Just mistyped an S. Yep. It is done. So let's send it out and back. If you guys just got here, hit that like button and subscribe. It helps a lot. Let's grab another one. We have a chest scan right there, CT scan of the chest. We are not really there are really just few MRIs, lots of CT, very few MRIs. This is a chest CT scan. This patient is a male patient. He is 51 years of age, and it says he has a colon cancer and has metastasis to the liver. He is under chemo, and it seems there should be some kind of secondary disease to the lungs because they have ordered a CT scan of the lungs as well. So let's go. If you guys have any questions, feel free to ask in the chat. For some odd reason, it didn't download. Where is it? It was supposed to download. It didn't download. I just saw it. Why didn't it download? Let's see. Let's grab it manually. No, it's not here. It didn't work. What? Just going to download it once again. Let's go. I need this. Let's just yeah, now it worked, I guess. Let's see if it opens up. It does open up, thank God. Thank you. Here it is. Let's go put it side by side. It seems we have a lung window and some sort of enhanced mediastinal window. Rip some lip outdoor said I have a MRI scan that I need a read on. If that's something you can do, or do you only accept MRI scan from doctors? I could read your scan, it's all right, but I'm only allowed to report scans in Brazil. It won't work as a proper medical opinion in your country. I don't know where you are, Rip, but if you, I could read if you have the digital images, the icon images of your scan. just feel free to share with me on the Discord. Just join the Discord, and there is a chat, a general chat there. And as soon as I finish this live stream, I can reply to your comment there, and we can see what I can do. Okay, I'll be glad to look at your scan. It's going to be fine. So just as a disclaimer, I can't really report scans outside of Brazil in a official manner. It's illegal. So this is a chest scan. So this patient has some kind of venous catheter right there, a deep central venous catheter. There are some tiny spots of ground glass opacities on the upper lobe. And let's see if we see anything else. Right there in the lungs, some micronodules right there, cortical micronodules. All right, another one right there, maybe a tiny one, some tiny spread out micronodules, some tiny ground glass opacities. Nothing major really. Yepers. Those micronodules usually aren't of much importance right there. Just incidental findings. Contrast enhancement. Let us look for acute thrombosis, aortic dissection, intraventricular and intraatrial thrombosis, all that good and deadly stuff. And there is none in this case, but it's really tough to look for calcification, vascular calcifications in such cases. So I have to go for a bone window, just as that, to look for calcifications, vascular, anything. I'm just going to do an NPR right there because this is an oncologic patient, so we must look for some kind of bone tumor that could present itself as a nodule on the vertebral bodies, posterior segments, and sometimes the rib cage. This patient has a partial fusion of the second and third ribs on the right. This is a anomaly, an anatomical anomaly, but it isn't really a disease. There is some spondylosis right there, nothing much, just a partially malformed rib cage on the right. These tiny spots of sclerotic lesions are usually just sparse ossification. They are really of importance, just like that. These are just bone aisles or anostosis, nothing much. This is just degenerative disease, such as this also. So there isn't much. See that catheter right there? This is a deep indwelling catheter for chemotherapy. Usually chemotherapy does that to you. You did that for chemo. So we only have tiny ground glass opacities on the upper right lobe and rare micronodules, non-calcified cortical and of random distribution throughout the lungs, nothing of major importance. So let's just report this and get on to the next one. Oh, Ripso, USA. Yes, indeed. I can't be your doctor in the US because I'm not a proper doctor there. I'm a specialist, a MD and a specialist in Brazil. So it's illegal to use my opinion and reports I do in Brazil or over the internet as medical advice in the USA. But I can informally chat with you about your exam and help you out as much as I can. Just join the Discord and we can talk over there. It's going to be a pleasure. And thank you so much for commenting on the chat and being part of this live stream. It helps a lot. Let's just grab a almost normal template. So degenerative disease, fine. I'm just going to describe those tiny findings. And we are going to go to our next exam. Just micronodules. And this is it. It seems this patient has a previous exam. Let's just say, let's look at what it says here. It says the same as I just reported, so it's unaltered. It's okay. So I'm just going to write it down as the same old. So nothing has changed. That is okie dokie. Oh. So fine. We are done with this one. Let's grab another brain CT scan. Brain CT scan, head CT scan, as you guys may please. This is a male patient. He is 60 years of age, and it says he has suffered a trauma to the head. So head trauma. It's downloading. Just a few more seconds and I'm going to open up the exam for you guys to see. Let's see. We are healthy, streaming healthily. You're welcome, Rip. I don't know your name, but feel free to contact me there on Discord. Yes, it's here. Let's just open up. Right there, we have a brain parenchyma window and a bone window just for the fun of it. And we're going to roll and look for signs of acute trauma. There is right there. There is right there. And also there on the temporal lobes, clear signs of acute brain hemorrhagic contusions. Also, we have a very thin and acute subdural hematoma right there. Acute subdural hematoma. We also have tiny spots of subarachnoid hemorrhage, acute, also right there. So this is indeed the case of severe head trauma. Right there, hemorrhage. Right there, acute hematoma. Subdural in nature. Acute nonetheless. Both temporal poles have been hit. Also, the temporal parenchyma close to the petrous pyramid on the right is also hit. Let's see if the straight gyrus are affected. They usually are. No. Since we have actual brain trauma, let's look for fractures. No fractures. Petrous bones, zygomatic arcs, fine. Sphenoid bones, base of the skull seems fine. Nose seems okay. Septum, bone septum okay. Maxillary sinus and orbits are looking fine. I'm just going to do an MPR right there to look for fractures of the face, facial fractures in the coronal, which is the best plane to look for facial disease, whatever it is. Yep. Temporal mandibular joints seem okay. Looks like a yeah, there is a partial dislocation of the left, right there, of the left mandibular joint. I suppose let's just go for a sagittal to be sure. No, it's just an open mouth. Not a dislocation, just a partial excursion, a partial regular normal movement of such joint. So no bone lesion that I can tell, just diffuse and at least moderate traumatic disease of the brain, acute hemorrhagic disease. This is quite concerning. I'm just going to report it. Overall, the brain itself is fine. For a 60-year-old patient, it's great. But now it isn't much greater than it was. It was supposed to be greater than this because there is diffuse, acute, traumatic, and hemorrhagic disease on this otherwise good-looking brain. There are some calcifications right there and right there. I'm also going to describe that. This is residual disease nonetheless. 0.4, fine. Just going to grab a normal template that has already vascular calcifications in, because there are some tiny vascular calcifications on the carotids, just to be sure. Excuse me, I need coffee. Fine. So let's go for the subdural, acute subdural hematoma on the left. So we have a 0.5. It's frontal, parietal, and temporal located. Also, there is some right there on the occipital lobe. So it's a diffuse hemispheric left brain hematoma. I'm going to describe it as that. Also, we have brain contusions on both temporal poles and close here to the petrous bone on the right, which are acute brain hemorrhagic contusions. And we have areas of acute right there, and right there. Acute thin subarachnoid hemorrhage on the parietal and frontal lobes. So let's take that phrase that says there is no hemorrhagic disease, because there is, and let's just summarize this exam to make it easier to read and much more straightforward. Also contusions. And acute subarachnoid hemorrhage. And we are done here. So, there are those tiny calcifications. I have to add that in. I'm just going to put it right there. Right there it is. So, this patient has been evaluated yesterday, the day before yesterday. And let's download the previous exam to make a comparison, since there are a bunch of acute findings, and it's good practice to do a evaluation, a follow-up evaluation into these cases of brain trauma. I'm downloading. It's going to take a few more seconds to arrive. Just bear with me as I sip my coffee once again. There are two kinds of people in this world: the ones that enjoy coffee, and the other kind that is always wrong. So coffee is great. Let's go. This is the previous exam. Indeed, brain contusions are there. They just have less edema because they were acute. Oh, there is right there acute subarachnoid hemorrhage was easier to look, to see, to detect than it is today. The hematoma was there, so I don't think there is much change. Much has changed. It's quite the same right there. Just normal right there. Acute hemorrhage right there. Just the expected evolution follow-up appearance of such acute traumatic lesion. So it's unchanged, it's the same, it's as expected. That's what I'm going to write down here on the follow-up footnote of this report. So follow-up has been done. It's itching. My ear is itching. I'm itching my itch on my ear, and it still itches. So right there. Let's grab a cervical spine, right? CT scan of the cervical spine. Can't. It's not accessible. We could do a let's see if we have anything here that could help us out. Yeah, out of interesting scans. Just good old. We have a orbit scan, CT scan of the orbits. It says it's a post-op scan, post-operatory, post-surgical of the orbits, and it has been done with contrast enhancement. I have no idea why. Let's see if I'm downloading. Am I downloading? No, just downloading now. It says here this patient has lost his right sight due to an accident, and he has lost his right ocular globe, his eye, and it's a follow-up scan. So I don't get why they did it with contrast enhancement, because if it's trauma there is no need for such enhancement, but whatever. I wasn't there to say don't do it. So oh yes, I know what happened. He was shot in the eye. Look at that. There are metallic fragments on a fracture of the frontal bone. There was also a medial fracture and consolidation of the medial wall of the right orbit. There is a very severe scar of such eye, a vertical scar right there. So this isn't your day-to-day trauma. This is a firearm, also another fragment right there, a firearm accident, assault of some sort, which led to a bunch of orbital fractures and the loss of the right eye. So the intrinsic muscles are there. For some reason the optic nerve is also right there on the posterior portion of the prosthetic globe right there. So this is a prosthetic piece. This is a normal globe. They did use contrast enhancement in this case. Why did they do that? It makes no sense. But you know, who am I to judge just a very horrible? There was a fracture of the anterior portion of the maxillary sinus and the floor of the orbit and the medial portion of the orbit, the bones of the nose and the frontal sinus. It was a freaking disaster. Let's just go for an MPR, because the best plane to analyze a facial disease is the coronal plane. So indeed we have a broken orbit floor, a broken medial wall, a diffusely enlarged orbital cavity, a prosthetic globe on the right. The muscles are fine. there is densification of the preseptal soft tissue with a bunch of anomalous calcifications and those metallic artifacts. There is also a fracture of the roof of the orbit. This is all the same thing. Let's just look for anything on the left eye and orbit. No, nothing major. Was there any brain damage? Was there any brain damage? I don't know. Might. Shockwave damage? No, it seems fine. So just a regular. Let's go for a sagittal view. Sagittal is fine. I like sagittal in this setting because there is diffuse deformities related to trauma, and trauma in itself is unique because every trauma setting is a proper disease on itself. It's really peculiar in nature. So there are fragments of sclerotic bone, maybe fragments of the bullet itself inside the right frontal sinus right there, and in the bone. So I guess we have as much as we can have to report this case. I'm just going to grab a normal template of the orbits because I really don't have a template for a major fracture like that. This isn't your everyday exam. Just going to say there is post-op signs on the soft tissues on the right. There are old fractures and deformities. There is a missing eye. And optical nerves are fine. Muscles, extrinsic muscles are fine. The intra and extraconal spaces are fine, and the bone is only bad on the right. So just it's contrast enhanced. Yes, just going to read what I just wrote or typed. Yep. And we are done. Just summarized and going to send it away. Fine. We are done here. Let's grab another scan. We have here a lumbar spine MRI. Thank God. Just for a change. We are in for 1 hour 13 minutes. Let's just scan this last exam. If you haven't already, don't forget to hit that like button and consider subscribing to the channel. It helps a lot. Really does. YouTube for small channels such as this is a bitch. Did I get it? Yes, I did. It's here. So let's split the screen. I'll put a T2 sagittal view right there. And also a STIR, a stir sequence right there, which is a fat saturated liquid weighted sequence that helps us look for disease that presents itself at increased liquid composition. So it's very clear for us. This is a T2 non-saturated because liquid spinal fluid is bright and the adipose tissue is also bright, and I can tell this is a brand new and well calibrated MRI scanner because the weighting is properly done, since the adipose tissue is a bit less bright than the fluid, and the fluid has very little to none flow artifacts. And as soon as we saturate, this is an STIR, this is a fat saturated T2, because there is some artifacts like that and like that, which are very common in non-STIR sequences. So it serves the same purpose, just to be sure. And as this is bright fluid and dark fat, so this is a T2 saturated, T2 weighted image. I can't really say much. This sequence isn't helping, so I'm going to put a T1 there. A T1 has dark fluid and bright fat, so T1 is good for morphology. I can see right there osteophytes, see, osteophytes. And also we have a decrease in height and signal intensity on the T2 weighted sequence of the discs. So this is mild degenerative disease, mild degenerative dehydration of the discs. Let's roll to see if we have disc herniations. No disc herniations, no. Discs, maybe a mild herniation right there. Nothing much, just a focal foraminal herniation. Just going to see which side is that. There we have an axial T2 weighted sequence. I can see the arthrosis is moderate, a moderate arthrosis. There is hypertrophy, there is subchondral sclerosis, there is reduction, decrease in joint space and osteophytes on the facet joints. And let's see which side is this. This is the left side, yes. So we have a focal and foraminal disc protrusion on L4, L5 on the left. Let's see if we can locate this image right there on this acquisition right here. Yes, we can. It's right here. See, it's right here. See, it's right there. So this indeed exists, and it's really close to the nerve root that is right there coming out of that foramina right there. So we have also a thickening of the yellow ligaments, which is a sign of chronic disease. We have also diffuse fat infiltration and hypertrophy of the perivertebral muscles. This is a obese patient, and he surely has chronic disease because this is a very severe and common sign of chronic pain or denervation of the muscles close to the spine themselves. So let's grab a template. I have a template for that. Of course I do. I'm not a fool. I do this every month, hundreds and hundreds of times for the left. I've done this for the left 15 years, so I have to have templates for everything, or else I'm going to be screwed. So there is no hemorrhagic disease, just osteophytes and dehydration of the discs. Just a sip from my coffee. So we can finish this up. This is L4, L5, and it's on the left. So this is of concern. Thickening of the yellow ligaments, arthrosis of the facet joints, hypertrophy, and it is what it is, spondylosis. Disc herniation or protrusion in L5, L4, L5, moderate arthrosis of the facet joints, thickening of the yellow ligaments, and hypertrophy and fat substitution, fat infiltration of the perivertebral muscles right there. So this is chronic, painful, mild disease of the lumbar spine. And we are done. It's gone. It's there. It's reported. We beat it once again. So guys, thank you so much for joining me in this Wednesday morning. I really appreciate. Hit that like button, consider subscribing to the channel, and there are a bunch of other live streams and videos already in this channel. I guess this is the 11th live stream, yes, and there is an entire playlist of this. Of course, I'm getting more and more used to live streaming, so the past live streams tend to be a bit slower, and just now getting used to actually speaking in camera. It's kind of hard, it's kind of exhausting, and it is what it is. I'll try my best to be here next Friday, the day after tomorrow, about the same time. So don't forget to activate notifications. As soon as I'm online, you get a notification and we can join this live stream. You can join this live stream and chat. So see you guys around. Thank you so much and so long.